Hi, I'm Joelle Puccio, and I'm here with my colleague Ria Tsinas. We're going to give you a condensed version of a presentation that we gave on November 3rd in San Diego at the Harm Reduction Coalition National Conference. These are some real quotes that we've heard from healthcare professionals. She should be in jail for what she's doing to that baby. This was from a nurse who was caring for a patient who was taking Dilaudid for chronic pain. This next one was when I was getting report on a patient that I'd had the day before. The previous nurse told me, "She's on meth." I said, "No, she's taking methadone." And then the other nurse said, "Isn't that the same thing?" "She can't breastfeed because she's taking methadone and is positive for Hep C." This was a neonatal nurse practitioner who wrote orders to prevent the mother from breastfeeding her baby. "Oh, thank God, you don't look anything like I expected you to." This was a NICU nurse greeting Ria the first time she came to the NICU to see her daughter Lola. This widespread misinformation is not limited to providers, but also passes on to parents as well. And these are some real quotes that we've heard from parents. "My baby will be mentally or physically handicapped because of my drug use." For most families, that's not going to be true. Even the drug with the strongest evidence supporting its harmfulness to a fetus, which is alcohol, still, not every baby has problems associated with that exposure. "I can't tell anyone about my drug use because they will take my baby away and put me in jail." Unfortunately, this one is true. It should not be true, but it is true for a lot of people. "My breast milk is bad for my baby." This one can be particularly harmful because for many parents, especially when their children are in the NICU, providing breast milk is the one thing that they feel like they can do that no one else can do for their child. I've been looking at this problem for many years from a lot of different angles. Since 2010, I've been the Director of Women's Services at the People's Harm Reduction Alliance in Seattle. In that capacity, I manage an all-female staff, and we provide female-centered programs such as drug use trivia, menstrual products distribution, and as of 2 weeks ago, pregnancy test distribution as well. As far as formal education, I have a bachelor's degree in nursing from the University of Washington. I have my RN degree from Lake Washington Technical College, and I've been working for the last 12 years at a mid-sized childbirth center and level 3 NICU near Seattle. A couple years ago, they finally let me revise some existing policies for maternal substance use, bringing them more in line with current evidence. And also, we wrote a new policy about breastfeeding and substance use. I've spoken on this topic a lot. A few recent ones are 2 years ago at the National Harm Reduction Coalition Conference in Baltimore. Last year, I spoke at a symposium convened by National Advocates for Pregnant Women and the National Perinatal Association on the topic. And just this last summer, I spoke at Seattle Hemp Fest about specifically cannabis and breastfeeding and pregnancy.
My name is Ria Tsinas, and here's a little bit about my background. I was Director of Women's Services at the People's Harm Reduction Alliance in Seattle, Washington for about 4 years. I was also an education specialist at Public Health Syringe Exchange in King County, Washington. For a few years, I also was a residential counselor at Downtown Emergency Service Center, which was a low barrier entry service and Housing First supportive housing agency in Seattle. I was also a shelter advocate with YWCA Angeline's Women's Center and Homeless Drop-In Center for Women in Seattle, Washington. And I am now a mom and a former drug user all the time, everywhere. This is a photo taken of me when I was pregnant on bed rest in the hospital. And I think it's important to show this photograph because people make assumptions about what it looks like to be a drug user and be pregnant. And obviously, I'm not the stereotype. So I just thought it was important for people to see that.
So here's a little bit of data about why this project is so necessary and important. By far, the most frequently used substances during pregnancy and breastfeeding are alcohol and tobacco. We have reports from the CDC that 10% of pregnant people smoked cigarettes in the last trimester. That's with 55% reporting that they quit during their pregnancy. So the actual number of smoking during pregnancy is probably much higher than 10%. Now, 9% reported using alcohol during pregnancy, and this is especially troubling because alcohol is the one substance that we have really strong data linking it to permanent damage. The number of pregnancies exposed to illicit substances, all combined, is only 5%. We have about 22,000 infants born each year with newborn opioid withdrawal. And I'm using the term newborn opioid withdrawal intentionally. Some people may be familiar with NAS, or neonatal abstinence syndrome, but I prefer newborn opioid withdrawal for a couple reasons. Firstly, it's much more precise and descriptive. With NAS, it's not specific what substances were used during the pregnancy or necessary effects or anything like that. With newborn opioid withdrawal, we know that it's related to opioids specifically. And that can be particularly important because there is one child, at least that I know of, that was put on morphine for several weeks who only tested positive for cocaine and whose mother only tested positive for cocaine. So we really want to make sure that we're not subjecting children to treatment that's inappropriate and even harmful. Overall, countrywide, we see about 0.5% of all hospital births involving substance exposure. So this really is quite a large issue.
This is a photo of me when I first held my baby, who was born at 25 weeks. Lola, my daughter, was a planned pregnancy, and I was abstinent up until my third trimester, at which point a lot of things were very chaotic in my life, and I was having a really hard time maintaining my abstinence. My partner continued to use while I was trying to stay abstinent. My father passed away. I decided I wanted to receive treatment and was not given a warm reception at the treatment center that I went to that accepted pregnant women. Then I had a premature rupture of membranes due to something called an incompetent cervix, or because of my drug use, I'm not sure. I was on bed rest in Seattle. However, I had rented an apartment in Eugene, so I decided what was best for me and my family was to leave. The hospital in Seattle refused to give me antibiotics. Upon my leaving to them against medical advice, I did check into a hospital in Eugene, and my daughter was born at 25 weeks. And I did have an infection, so I often wonder if my healthcare was held hostage and my daughter was born early as a result of that.
We got involved in this project after a presentation that I did here at HRC 2 years ago. Lynn Paltrow of National Advocates for Pregnant Women was at that presentation, and she recommended me for the symposium in Nashville last year. At that symposium, a group of us experts agreed that a standardized, comprehensive, nationwide, or possibly worldwide guideline was needed. So we began recruiting parents, other experts, and starting to organize our group and subgroups. We are organized under the National Perinatal Association, which is a nonprofit which was established in 1977. A major goal of National Perinatal Association is including all disciplines, including parents. They focus on education, advocacy, and integration of other projects rather than duplicating things that have already been done. They put out position statements, clinical guidelines, family support, and policy change in the Journal of Perinatology, among other places. Some of the recent things that they've worked on have been around late preterm deliveries, RSV, which is a virus that affects NICU babies, NICU psychology, which is a really overlooked area of study, as well as transcultural care. The most important goal of this project is to facilitate cooperation between providers, and that doesn't just mean healthcare providers. That means parents, lawyers, healthcare workers, social workers, hospital administrators, everybody working together. We want this to be practical and useful because there's a lot of references out there and various other resources that are just not very useful when you're in the moment and you've got 10 minutes to get ready for this patient. What are you going to look at? Another really important part of this is that we want it to be free so that it's not only accessible to parents, who are the most important person that needs to access this, but also to smaller healthcare providers, maybe freestanding offices or smaller hospitals, places without institutional access. We also want it to be comprehensive. So we want it to be useful to every single person, including the patient who interacts with them on this journey. We expect it to be in multiple languages. We want to have printed materials, cell phone app, website, everything. Another crucial part of this project is that it makes sure to maintain a harm reduction framework. We define that as any positive change as defined by the pregnant person and not by us clinicians. We want this to encompass everything that that person needs, from the time that they're just thinking and planning this pregnancy all the way to discharge from care. So that's going to include standard prenatal care, which is prenatal vitamins and checkups and ultrasounds and diet and exercise and all that kind of stuff. It's also going to recommend abstinence as the least harmful choice in our current legal framework. I want to stress that abstinence is not the least harmful because of anything to do with drugs, but it's the least harmful because of the system that we have set up. Other focuses that make this project a little bit revolutionary are that we are going to talk about safer drug use, such as, using clean needles instead of dirty needles, or smoking rather than injecting your drugs, or even just finding a babysitter or not driving when you're high. Another aspect that we're going to talk about is reduced use as an excellent goal. So anytime anyone makes any positive change, we're going to celebrate it, as opposed to our current systems, which tend to just say abstinence or nothing. The work group has 3 chair people who oversee the entire project, as well as 4 subgroups with their own chair people. We've got the Parent and Family Toolkit, which Rhea is the chairperson of, and the Clinician Toolkit, which I am the chairperson of. We also have a legal and administrative toolkits as well.
It's important for the project and for providers to be patient and family centered because pregnant people are the experts of their own bodies. And it's important that the toolkit reinforces that as well, because parents need to be empowered to be good advocates for themselves and for their children. And service delivery should be implemented based on collaboration, meaning pregnant persons are feeling heard and they have a trusting relationship with their provider, and together they come up with a plan that it serves both parties with the hope of the best potential outcome. One of the things that's very frustrating about the way the traditional system is set up is that men and partners aren't necessarily held to the same expectations. Treatment isn't mandated for partners, at least in my situation, and support isn't always offered to partners or men. Most of the time, it's focused on the responsibility of the woman or the person holding the child. So there's definitely a disparity in equity of care and expectations.
Trauma-informed care is really something that we're trying to get better at in all segments of healthcare, but is particularly relevant to this population for a few different reasons. History of trauma is something that we have to consider when we're dealing with all female-identified patients and patients who have vaginas and uteruses, and we know that the prevalence of trauma is higher among women who use drugs. Another thing that I think healthcare providers forget a lot is that trauma can be experienced or triggered while obtaining medical care. Because for a lot of folks, every time they have tried to obtain medical care, they've perceived the response as judgmental or punitive based on their drug use. So oftentimes when I'm speaking to other providers about this, they don't realize that just their very presence, the scrubs that they're wearing, the office that they see patients in, can be a source of trauma or a trigger of trauma for their patients. Another area that we don't often address is trauma experienced by providers. Working with people who are in a crisis moment in their lives can be extremely emotionally draining, and we need to make sure that we're taking care of each other and giving each other opportunities to process that kind of trauma. On the other side, we also, as clinicians, have to make sure that we're not making assumptions about trauma experienced by people who use drugs. Oftentimes, you'll hear really well-intentioned clinicians just assuming that every single female person who uses drugs has been raped or has been beaten or has some sort of trauma in their background, and that's why they use drugs. And this is also a really minimizing mindset that doesn't really acknowledge the whole personhood and the varied experience of pregnant people who use drugs. This is a sample of our work in progress trauma section, and it, as you can see, it focuses on some really important things that may or may not be obvious to folks, such as setting a welcoming tone when women and partners arrive. And it's really important to do this consciously and make a real effort, because we can't just assume that our normal tone is going to be welcoming to people who have experienced trauma at the hands of healthcare providers in the past. Another really important point that we're including is that last one, which is recognizing that problem behaviors are an attempt sometimes to cope with past experiences or current stressors. For example, I've seen so many times that parents react negatively after being told that the custody of their children is in question. This is not a problem behavior. This is not aggressive behavior. This is the behavior of any parent after being told that they may not be able to have contact with their child. It's not a problem. It's a normal response.
Trauma-informed care is very important because providers really need to understand the role that violence and victimizations play in the lives of women seeking services. And conversely, dominance over or feeling unheard can also bring up a lot of trauma. In addition to that, pregnancy of itself can be rather traumatizing because people don't tend to feel like they have control over their bodies, which was my case as a survivor of sexual trauma. Pregnancy brought up a lot of those old issues which I thought that I had dealt with. So it's important that when providing care, providers keep that in mind. The Family Toolkit, in the Family Toolkit, we collaborate with clinical and legal work groups. We share information. If we have a legal question or a clinical question, we'll ask. The clinical group will write a pharmacology section, and the family group will write it in a more comprehensive way. And also, the development of provider database allows for people in any state to look up a provider that subscribes to the ideas listed in the paper.
One of the most exciting things about this project to me is the creation of a harm reduction provider database. So the concept of this is a tool to provide for parents and prospective parents when they're seeking care to find a provider that's going to take a harm reduction framework in their care. So it involves a list of promises to be signed by providers before they're added to the database. 4 main areas. Patient autonomy means the provider believes that the patient is the best person to make decisions about their body and their health care. Harm reduction means that even if what the patient chooses is different from what I, as a provider, think they should choose, I'm still going to support them and I'm still going to provide them with excellent care. Shared decision making means that we are going to work together to form a care plan based on your values, not necessarily my values. My job is to provide information, and you get to make the final call. Informed consent means that we are going to work together to reduce the harms of some of the mandated reporting type stuff that we're required to do in certain states. So that means before I administer a urine test or other form of drug testing, I'm going to let you know why I'm doing it, either because I think it's going to inform your care plan or because I'm required to do it. And I'm also going to let you know what the consequences are of those results and how I'm going to work with you to try to reduce those negative consequences. All of these are described in more detail on our website, and if you are a provider, you can sign up at our website to be on this list. We've also begun work on a patient bill of rights of sorts, for lack of a better word, and we're looking at various things that other groups have put out that might help inform us or that we might possibly adapt to this project. This one is from Vancouver Area Network of Drug Users, or VANDU, and I really like it because not only it says what your rights are, but actually what your provider should do if they are indeed a provider worth your money and your time. We've also got another one that talks about what a good provider looks like, and that one is here. We really like both of these. This one especially because it mentions they won't judge you for mental illness and substance use, things like that. So we really want to let people know that they deserve the best care and how to get that best care.
In order for families to feel empowered and be able to have the best advocacy for themselves and their care, we've comprised a family toolkit just for families, which is divided into 4 main sections. It's the contemplation or preparation for pregnancy. It includes prenatal care, labor and delivery, and postpartum. This is a sample of the prenatal section written for the toolkit. Of course, it's a work in progress, so we're still going over and editing things, but I thought it was important to just show the sample that we have going in terms of prenatal care for families. Again, this is another sample section from the family toolkit of Pharmacology, which was taken by the clinical group and rewritten in a more comprehensive format for families, and this may be edited again further.
So besides the trauma-informed care section from the clinical toolkit that we showed earlier, we've been making progress on 2 other sections. One is the effects of substance use on pregnancy and pregnancy outcomes, and the other that I'm going to discuss first is the pharmacology and physiology section. We are covering 5 classes of substances: alcohol, tobacco, cannabis, opioids, and stimulants, with caffeine included among stimulants because it has really very similar effects to cocaine and methamphetamine. They all act on pregnancy in really similar ways. So we're going to talk about, with each class of substances, what it is, what treatments are, a brief overview of the effects on pregnancy and lactation, as well as discussion of overdose prevention and treatment and withdrawal signs and symptoms. This is a sample from the clinical toolkit on the pharmacology and physiology of stimulants. If you're having trouble reading these slides, they're all available on Joelle's Facebook and Twitter and Instagram.
This photograph on the left is a photo of my daughter's isolette and all of the equipment that they were using to keep her healthy and alive. On the right is a photo of me feeding my daughter with a tube. It's a nasal tube that goes up the nose and down the throat and into the stomach. As I mentioned earlier, I had an incompetent cervix. I was 35, which in pregnancy terms is really, really old. And so I had a premature rupture of membranes. So it's important to note that the cause of my preterm labor may never be actually known if it was a direct result from my drug use or because of my body.
The section in the clinical toolkit on the effects of substance use on pregnancy and pregnancy outcomes is probably going to be the most difficult and controversial one that we work on. And there's several reasons for that. One is that we do our best to be evidence-based, and we have been studying the effects of substance use on pregnancy and pregnancy outcome for several decades, but the research is extremely difficult to interpret because there will be some study where the data looks like their results are equivocal, or even possibly kids exposed to substances in pregnancy do better sometimes on the outcomes. But then you go down to the discussion, and you have to wonder if the authors of these papers are looking at their own data or at something else, because sometimes you'll get these equivocal results, and then in the discussion it'll say, and this data clearly shows that X substance is harmful to pregnancy and the fetus. So this becomes a really big problem, not only for interpreting the data, but also for just reading papers in general. It oftentimes will take me several months just to read a short 5 or 6 page paper because some of the claims that are made are so outrageous that I have to follow them up, and you can end up going back 3 or 4 or even 8 or 10 papers before you find the actual original data that these claims are based on. So it kind of turns into a game of telephone where the original data was pretty equivocal, the authors reached these kind of bizarre conclusions, and then each author that used that data after them kind of amplified that bizarre interpretation of the data. Another part that can make interpretation difficult is that most studies focus solely on the implications for the embryo or the fetus, and they don't really look at the pregnant person as a person who is also a patient in this process. So we're trying to write these sections to focus not only on the outcomes for the fetus, but also for the pregnant person. We also want to include information about treatments available and whether those treatments actually work and are safe for the pregnant person and not just for the fetus. This is a sample of our effects on pregnancy and pregnancy outcome sections, and this one is probably the roughest, least fleshed out section that we have so far, but I just wanted to give you all an idea of what we're working toward.
This is a picture of my breast pump contraption. In the early days, it's really important to pump, obviously, because I'm tube feeding, so I can't breastfeed. One of the major ways to bond with your child is through breastfeeding, and that right was almost taken away as a result of bad reporting on behalf of a social worker in the hospital who claimed that I was a daily drinker. So she tried to order that the doctors and nurses not allow me to breastfeed, and I fought back because I felt that, A, it was wrong, incorrect information, and B, she's not a doctor, so she had no right in intervening in the care of my daughter. I think it's really important to maintain good records because situations like this can happen and develop deep seeds of mistrust between a patient and a provider. This is a photo on the left of my primary care nurse, who was the first person to let me hold my daughter, and the first person that taught me how to feed my daughter. And the person on the right, Dr. Leonard, was a neonatologist that was there when my daughter was born and oversaw much of her care along with 4 other neonatologists. Not all providers are bad. It did take a long time for me to build trust between them and myself and vice versa. But the outcomes are much more positive when you have providers that believe in you and believe that you are capable. And when a person is pregnant and having a child, there's no better time to help empower them by believing in them.
I'm going to do my best to report on the progress for the legal toolkit work group, although neither Rhea or I are part of this group. What they've done so far is developed a 1-hour-long presentation for lawyers about the evidence-based research we have on perinatal substance use. So far, this presentation has been given to over 200 lawyers in New York State, and we're working on expanding it to other states as well. They've also been doing amazing work assisting the other groups with legal questions for families and clinicians. Some things that they're working on for the website are going to be really, really amazing, useful tools for folks. So for attorneys, there's going to be a list of expert witnesses willing to help in defense cases. There's also going to be a motion bank to assist lawyers in defending parents. They're working on a series of essays that I'm extremely excited about to let clinicians know what the effects of mandatory reporting are on their patients. Because oftentimes, as clinicians, we just think, oh, I reported it to CPS and it's all fixed now. No more problems. So really letting clinicians know what happens after that report can do a lot to change the way that we look at those reports and the way we communicate with our patients about those reports.
This is a photo of myself and my daughter when she first came home from the hospital. She was still on oxygen, and she weighed just a little over 5 pounds, which was huge because she was 111 when she was born. I just wanted to point out that the outcome for me may have potentially been different because I am white, somewhat educated, and have a background in social services, and I have an awareness of the system, and I'm not afraid to speak up for myself. But not so many people are as lucky, so I just want to acknowledge my privilege. And I really think it's important to highlight that just because I did it doesn't mean that everyone can, and my story isn't particularly being used to be a poster child for outcomes for all pregnant people who use drugs.
To build on what Rhea was saying about privilege, I could talk about this for a whole nother hour-long presentation, but just a couple quick facts. This graph has the infant mortality rates based on race for our country. So as you can see, there's one group of folks that has about double the infant mortality as white people or Hispanic people, and that's black children. So they're about twice as likely to die in the perinatal period as white children. For pregnant people, the risk is even greater. It's increased about 350% if you're black. So that means a black woman in this country has 3.5 times more chance of dying in the period surrounding childbirth than a white person does. So this isn't just a perception or something that some people think. This difference and disparity in healthcare outcomes is measurable, and it's happening, and we're all a part of it. So as I was at the conference talking about this work, so many people said, we need this yesterday, we need this last year, we need this 100 years ago. And I know that that's a big frustration for all of us who are working in the group, is that we can't get it done fast enough. So just a quick note on what our next steps are. All of this stuff will be published in the Journal of Perinatology with open access, which means that it will be freely accessible to anyone on the internet anywhere without having to pay for it. Before we get to that point, we need to finish writing and reviewing sections within the group, send them for review to experts outside of the group, submit them for publication, upon which point they'll be submitted to whatever the publication's formal review process is. And the next sections that we're working on for all the different subgroups are screening, treatment, coordination of care, and prenatal care and perinatal education.
I really want to stress the importance of outreach for 2 reasons. One, we really want families to be able to participate in having a voice, because right now I'm the only family person on the family toolkit, and my experience is unique. And so we want all different types of people from all different types of backgrounds to be able to contribute to the toolkit for a diverse voice and breadth of experience. And the other reason is we want families to be able to know where to access services and answer legal questions and find providers. And the best way to do that is to outreach folks in needle exchange programs, drop-in centers, homeless shelters, public health, or community health clinics, because we want to meet people where they're at. This is a photo of my family on Halloween. My daughter is healthy, happy, developmentally right where she should be for her corrected age, and we're just like any other normal family.
Please, please, please feel free to email us with any questions, or you can contact Joelle via Facebook, Twitter, and Instagram. If you would like any of the citations or sources that we used for our data presented in this project, let us know. Or if you have any interest in reaching out to assist, we especially need parents and social workers, hospital administrators, and we also need lawyers right now. If you're a parent who's considering helping participate in this group, please be assured that we will do our very best to protect your safety, confidentiality, and even anonymity if necessary. We recognize that outing yourself as a parent who used drugs is dangerous, both physically and for your family integrity. So we make that our very highest priority when we're asking for people to participate in these projects. Thank you. As with everything I do on the internet, I need to state that this presentation is my own personal presentation and does not represent the views of my employer.